So at this time, I have the pleasure of introducing Ambassador Deborah Birx, who is an innovator problem solver using her global experience in big data for action. She has extensive experience in the development of diagnostics, therapeutics, and vaccines for improved health, disease prevention, and health security. She was the past White House coronavirus coordinator, and she currently is an independent board director of NanoLive Corporation. Dr. Birx will present on bacteriophages in the treatment of antibiotic-resistant bacteria. Dr. Birx, the floor is yours.
Thank you. It's so good to see you, Kevin, and your team, and have people on late at night. For me, it's easy. I'm on the West Coast right now, so it's not late yet. So really appreciate the opportunity. But let's talk about phages. I just wanted to make sure everyone was aware of that piece on the CDC website. I think it's quite nice. It's a nice summary for people who say, why now and why are you talking about that? I think it shows it quite reasonably why we're talking about that. So what are phages? And these red ones and yellow ones are phages. They're quite interesting. Those tails are how they attach to bacteria, and then they inject their DNA right into the bacteria. They are just like our viruses, our human viruses. They're very species specific. So these phages that have been around for millenniums are very species specific. They will only infect a very specific species. These receptor tail fibers that they have are very specific. The interesting thing is that though they can invade a bacteria, replicate in that bacteria, and kill that bacteria every 22 minutes. So it's one of the few things that we have that are replicating faster than bacteria, or at least closely to the same replication rate of bacteria. And that will become very important in why they're effective. So they're everywhere. They only attack their species of bacteria. So these phages are very particular. There's only Pseudomonas aeruginosus phages. There's only Staph aureus phages. There's only Klebsiella phages. They don't cross-react across bacteria. So this is actually quite important because this is a way you could actually kill bacteria and keep the entire normal human microbiome intact. And imagine what that would be instead of broad spectrum antibiotics, being able to have your human microbiome completely intact and completely resolve your Staph aureus bacteremia or your sepsis. So to me, that's the most exciting part of this, because a lot of the consequences of long utilization of broad spectrum antibiotics is C. difficile, fungemias, and other infections. So these are the tail fibers. This is the capsid. This is where the DNA material are kept. And this is how it injects into a bacteria. So how does this happen? So here's a nice bacteria. It gets bombarded with these phages. The phages are injected, the phage DNA. So just like everything else, these viruses have to take over the cell in order to be productive. And so the phages go into the cell, replicate, utilizing the bacteria's machinery, replicate themselves, and then blow up the bacteria and are put back out. So this is considered amplification. So it's pretty exciting when you think about what they could do. So why phages now? Believe it or not, Eastern Europe has been using phages therapeutically for the last 20 or 30 years. They won't even go back and do a clinical trial because they're like, we use it, it's successful for us. The clinical trials have not been done in Western Europe or the United States, and so there are no approved therapeutic phage. There are phages now being used widely in agriculture. So they're being used for fruit and vegetables and livestock to prevent those bacterial infections without antibiotics, which is also quite exciting because you can imagine decreasing the antibiotic use in domestic livestock could be quite important. There's large agricultural phage companies, both in the United States and in China, that are selling phages for agricultural use. But there's been very few clinical trials for human use. But we do know that there's a huge increase in antimicrobial resistance, and bacteria talk to one another. They're able to communicate the plasmids that are responsible for antibiotic resistance. And so we've been right on that teetering edge of just keeping up with antimicrobial resistance to date, which is great. But finding an alternative and an entire different class of abilities to actually kill bacteria could be quite important. As I discussed, is phages can act on antimicrobial resistant bacteria, which is quite good and quite effective. And so I'm going to show you some data. People have known about these for over 100 years. When you put down a lawn of bacteria on an agar plate, and you put phages on top of the plate, you can clearly see these, what we call phage plaques of killing the bacteria. And they've been used as compassionate use cases in the United States probably for the last 20 years. And so just as to show you, these bacteria isolates are very phage specific. Let's say this is phages that are against Pseudomonas aeruginosa. Not all phages can hit all strains. And so you have to have even with Pseudomonas, you have to have a cocktail of phages to be able to do that. So what do we do? I'm helping a phage company right now. Its name is Armada. So you have to grow these phages in their host. I just spent a lot of time talking about how they're very species specific. So you can't grow them just in a broth of just an agar broth. You have to grow them in their actual bacteria so that you can get replication. And so let's say you're making Staph aureus phages, you take the Staph aureus, you put it in a fermenter, you add your phages, and then you purify. Now, this is the tricky part and the important part. You have to actually purify the phages to a very high purity because we all know cell wall proteins from bacteria are very reactogenicity to humans. So at Armada, they've spent a lot of time discovering the right phages for the right bacteria, developing them preclinically, and then actually manufacturing them and proving that they're pure, and they've gone into clinical trials. Many of the other phage companies in the United States have really worked primarily in compassionate use because when you're seriously ill and you need phages, they don't have to quite be as pure because you would accept a level of side effects if you're that ill and you have no other therapeutic alternatives. But I believe that FDA will never approve phages as an alternative to antibiotics or an augmentation to antibiotics unless someone does the clinical trials and proves in a well-controlled state that this is an important new modality. So the good news is the DoD has also agreed with that, and they've given Armada about $22 million. The Cystic Fibrosis Foundation also supported Staph aureus development for cystic fibrosis, and now Armada has taken that into non-CF bronchiectasis. And the DoD is supporting Staph aureus bacteremia phage development to really combat severe bacteremia. So these are the clinical trials that have been done. There's been 3 phase 2 trials done, and I want to just show you some of the data and why I think this is pretty promising. So in the CF trial, so this was inhaled anti-Pseudomonas aeruginosa phages. They were very safe. We take sputum from those patients before and after treatment with phages in a set time frame, an hour after to the next day, to really look at how long you can actually decrease the Pseudomonas. After doing the CF trial, phase 2 trial, we moved to non-CF bronchiectasis because they also have structural abnormalities of the lung, and about 30 to 40% of them are infected with Pseudomonas aeruginosa. And so we were able to do a trial because there's no FDA approved treatment for non-CF bronchiectasis. We were able to do a placebo-controlled phase 2 trial. Some of the patients were on inhaled antibiotics. The majority of them were not on inhaled antibiotics. We enrolled 48 people, the majority over 12 months. And what we saw in the majority of the patients is a significant reduction in Pseudomonas colony forming units that's in their sputum across the board of median at day 11. They were dosed for 10 days at day 11 of a half log. About a third of the patients, or 30% of the patients, had a 2 log reduction in their Pseudomonas titers. So we're thinking that this is strong without significant side effects, that this could go into phase 3 trial. In parallel, we were testing intravenous, so delivering phage intravenously in people who have bacteremia. We enrolled 50 subjects. 42 of them were subjects that had what we call complicated bacteremia. That is recurrence or an actual nidus of infection that continues. So 42 of those subjects had complicated bacteremia. It was a 2-to-1 match. The people were given phage every 6 hours for 5 days. We were able to give up to 2E11 phage, so 5E10 every 6 hours, so 2E11 over 24 hours. So extraordinarily high dose, which we did to really give it the phage an optimal chance to seek out that bacteria and find it from an intravenous injection, but also to prove that the phages are incredibly pure. What we found is something very interesting, and hopefully you all find this interesting too, because this gets at the very heart of how phages were hypothesized to work in the human body. So these individuals received their phage, it was injected into the intravenous space, and then we sampled for persistence of phage. And we found 2 different, so this is at the first dose, this is extended time points after the first dose, this is the first hour, this is out to 3 or 4 hours. We saw half the patients divide into these 2 very different platforms of analysis. We saw patients who had persistence of phage way out in 3 or 4 hours. Now, this is injected into, 6 liters of blood, it circulates. The only way you can have viable phage still found in the intravascular space 3 hours later is if when you injected it, it homed to that bacteria, found it from that intravenous injection, killed that bacteria, and re-released. Remember, that cycle is 22 minutes. And so out to 3 hours, it's showing that it's finding Staph aureus, infecting the Staph aureus, and then killing the Staph aureus and being re-released into the bloodstream. So these are all of the patients who receive phage. It doesn't show the placebos. I'm still blinded to the clinical data. And when we went up to 5E10, that's shown in the blue here and the blue there, we saw the same pattern. So it really wasn't dose dependent. We saw persistence in a group of patients, and we saw what we would call clearance in a group of patients. We then modified the protocol to draw blood over the 5 days, an hour after receiving phage. And this is very interesting to me. It will be very important to see what this looks like clinically, in that some patients after day 2 didn't have detectable phage 1 hour post at day 3, potentially illustrating that there wasn't Staph aureus available to be found, as opposed to this patient in green who didn't see that until day 5, and this patient who had persistent phage still being able to find Staph aureus in the body 5 days later. Now, I neglected to mention all of these patients with this complicated bacteremia obviously had come into the hospital, received broad spectrum antibiotics. It took about 3 days to enroll them into the trial. So they had been on broad spectrum antibiotics for 3 days, yet half the patients at 72 hours still had enough Staph aureus circulating actively, despite broad spectrum high dose antibiotics, that the phages could find and self replicate. So we're working on phase 3 designs for this population now to really start that definitive trial in the next 12 months. But I believe in science and data. I believe in doing the hard work of doing these clinical trials. Obviously, they're not cheap, but someone has to actually prove that this is superior to antibiotics if it's used in an augmentation, or non-inferior if we do 10 days or so of phage without antibiotics. The great thing is Armada built a full GMP facility, so we have the ability to make all of these phages in a full GMP environment. This is our QC labs, and this is our state-of-the-art fill and finisher. So we can fully commercialize on site, which was important to me, that you're not dependent on contract manufacturing. So it's been an exciting couple of years that I've been here with this team now, and I just wanted to really thank you for the opportunity to talk about phages and to really remember that these clinical trials are only doable because site investigators talk to patients and patients enroll in these trials, so that we can really understand new drug and new drug developments to get drugs available for the next individuals. So really appreciate your time. And of course, we'll take any questions